Hi, my name is Linda D'Onofrio, and I'm a speech-language pathologist, and I specialize in a number of things, but one of them is oromyofunctional disorders, and that's what I want to present on today, the evaluation and treatment of oromyofunctional disorders. And for folks who have no familiarity with this, it really is about the structure, the muscle function, and the behavior of the structures of the face, including the jaw, the lips, and the tongue. A little bit about my background and how I came into this clinical specialty. When I was a clinical fellow, I was working both in the schools, in the hospitals, and in private practice. And I really began to realize that a lot of my kids weren't progressing in a typical way. One of my placements was a specialty in oromyofunctional disorders, and it really became something I was interested in. As soon as I started practicing, I started sharing reports with pediatricians, orthodontists, and ENTs, and continued referrals kept rolling in, so I continued my education in this process. I've now seen between 300 and 400 clients that qualify as having OMF disorders. And these are some of the contentions that I have about the way I do therapy and the way therapy is often done with these same children in other environments. One of my contentions is that caseloads in school are extraordinarily high, and one of the reasons they're high is because of poor differential diagnosis. A lot of children are seen for articulation disorders that I believe have underlying motor-based speech disorders or oromyofunctional disorders. Children who've been working on articulation targets for more than a couple of years, especially if there's not an underlying cognitive diagnosis or another developmental diagnosis, I feel don't have an articulation disorder at all, but are really looking at something else. I believe that properly diagnosing and treating OMF disorders can really move a child much faster through speech therapy later on after these are fully addressed. And over and over and over again, I have found that you can improve speech without working directly on speech. For the first half of this presentation, the things that I'm really hoping to cover and that everyone has a solid understanding on when we get done is to understand, and the number one question I always get is, how does an oromyofunctional disorder impact articulation? What's the point? Why are we doing this? What are we looking for? I want all speech pathologists, but especially those in academic environments, to do better oral peripheral examinations. We all are basically trained in how to do an oral periph, but a lot of speech pathologists, they're looking in that space and they really don't know what these structures mean, how it impacts how they're going to develop treatment for that child or that adult. I want to be able to help you distinguish a difference between structural differences and structural disorders. Everybody looks a little different inside their mouth. When it's a problem, it's a problem. And overall, just how does bony structure and muscle function impact articulation even in normal artic? I want to help everyone create measurable goals from the evaluation, know when to refer out to an area of specialty, know how to build treatment goals within your work environment. And again, most importantly, understanding when you should refer out and when you should treat, and knowing within your scope of experience and practice how that should look. The number one question I get, especially from school-based SLPs, is what is an OMF disorder and what does it have to do with how I'm practicing speech every day? As we go through this and the way this presentation is set up, I am not saving all the good treatment information to the end. I get often frustrated when I go to a long presentation, all the treatment is compact at the end, the presentation runs late, and then all the really juicy stuff kind of gets compressed or pushed aside. So as we go through this, treatment considerations are placed throughout the presentation, and these are red flags that I hope will get you thinking about your clients right away. A palate that is too narrow or a palate that is too wide will impact SH, CH, and J. An excessive overjet, that horizontal relationship between the top teeth and the bottom teeth, will impact alveolar sounds. An underbite, when the bottom teeth exceed in the space between in front of the top teeth, will move the point of contact to alveolar sounds. It'll either move the way the tip operates up into the alveolus, or it'll create contact further back on the tongue. A lingual frenulum that is too anteriorly placed will distort L and R, and in little kids will present as groping behavior. It is very common for children to come into our clinic with the diagnosis of dyspraxia, and really what they have is restricted lingual frenulum.
Yeah.